The next speaker is Jedd Wolchok. Doesn't need much introduction, talking about trial design for immunotherapy, and his talk will incorporate use of pharmacodynamics in the design of clinical trials for immunotherapy. Jedd.
Thanks to the organizers for the invitation to present at this important symposium. My name is Jedd Wolchok, and I'm going to talk about challenges of trial design incorporating pharmacodynamics for immunotherapy. These are my financial disclosures. I think that many in this audience are aware of the development of a class of agents called checkpoint blocking antibodies. The first of these to receive FDA approval was a drug called ipilimumab, which blocks a critical immune checkpoint called CTLA-4. CTLA-4 normally exists inside the T cell, and once the T cell becomes activated, it translocates to the immune synapse and turns off the T cell as a means of maintaining immune homeostasis. Ipilimumab blocks CTLA-4 and therefore allows T cells to proliferate more and become more activated than normal physiology would allow. In studies that were responsible for him being awarded the Nobel Prize in 2018, Jim Allison showed that if you treat a mouse with transplantable colorectal cancer with a CTLA-4 blocking antibody, you get long-term tumor control. However, all of the tumors grew before they regressed. And indeed, this became an obstacle to straightforward drug development for this class of agents. And in fact, the only way for the full activity of ipilimumab to be captured was through overall survival and not through any surrogate endpoints. And what you could see is that with ipilimumab in phase 2 and phase 3 studies, there was about a 20% long-term survival, 5 years or longer, of patients with metastatic melanoma, which, although it's still an unacceptably low number, it was quite a bit better than what the standard of care was using chemotherapy from just a few years prior. Now, one of the challenges for immunotherapy clinical trials is that there are different patterns of anti-tumor response that have been observed. There are conventional patterns, and then there are also novel patterns of response. And these novel patterns of response represented a challenge for standard metrics of clinical trial evaluation. For example, in one of the early studies of ipilimumab, one of the endpoints was progression-free survival at week 12. And what you can see here is a patient of mine who was treated in one of the early ipilimumab studies with really unequivocal radiographic progression at week 12, yet the patient felt better at that time point. And with additional observation and no further anti-cancer therapy, had a long-term regression of melanoma, yet they were scored as drug failure. In order to answer this, we've come up with some perhaps pharmacodynamic endpoints to try to introduce, one of which is the use of immuno-PET scanning, and these are data resulting from a collaboration between Dr. Nita Panda-Taskar at Memorial Sloan Kettering and myself, looking at a CD8 minibody, a small antibody fragment bound to zirconium, which here you can see is taken up by various immune-related organs in the body, including the spleen, bone marrow, and lymph node. However, when you compare side by side a standard FDG PET with the immuno-PET, you can see that both imaging modalities reveal uptake of the radioactive tracer in this soft tissue metastasis of melanoma. And you would be tempted with just the FDG to assume that this is only a tumor nodule that is refractory to therapy. But using the mini-body, you can see that this tumor is also full of T cells. And so you might be able to get a better handle on true outcomes in this type of study with unique imaging modalities such as this. I'd also like to highlight a challenge that our field is having with second-generation immune modulators, where we are now seeing that even though these drugs may not cause anti-tumor activity in terms of obvious regression, they should not be abandoned or parked just because of this. We really need to first evaluate whether these new immune modulators are showing pharmacodynamic activity in terms of immune activation. And I'll just give one example today of a class of drugs that target a molecule called GITR. Could also be true of a molecule called OX40, and these are both members of the TNF receptor family. They are agonist pathways, and there have been numerous clinical trials evaluating them, all of which have shut down because of lack of classical anti-tumor activity. I would posit that these clinical trials serve as examples of studies in which monitoring pharmacodynamics should have been really moved to a primary outcome measure along with safety and any anecdotal observations of anti-tumor activity. So as I mentioned, a little bit of background, GITR is a member of the TNF receptor family. Antibodies have been developed which agonize GITR and have been shown to overcome immunologic tolerance. We did some early studies with an antibody shared with us by Professor Shimon Sakaguchi from Osaka University, and showed that a single dose of an antibody called DTA1, which is an agonist for GITR, given to a mouse bearing a B16 melanoma, more than 50% of the time that will cure the mouse. And in fact, that is associated with about a 50% reduction in the number of suppressive regulatory T cells inside the tumor. And so this is an important observation because it shows what a potential pharmacodynamic marker could be for this class of drugs. We had the privilege of launching and leading a first-in-human clinical trial of a GITR agonist agent called TRX-518. This was a single ascending dose clinical trial in patients with advanced refractory solid tumors. The endpoints were safety and tolerability, as well as pharmacokinetics and pharmacodynamics. And I just would like to give credit to my colleague, Dr. Roberta Zappasotti, who led the pharmacodynamic assessment for patients in this clinical trial. And this work was published in 2019 in Nature Medicine. So this gives you a sense of the patient population in this clinical trial, many different diseases, a wide range of doses used in deference to the potential safety issues, which thankfully did not arise, ranging from 0.005 mg per kilo up really to 8 milligrams per kilogram. And the patients highlighted in gold are those patients who generously volunteered to have pre and post-treatment tumor biopsies for pharmacodynamic assessment. When we looked at peripheral blood, we saw quite satisfyingly that the drug was hitting its target in that there was a decrease in the number of regulatory T cells in both the total Treg population as well as the GITR positive Tregs. Importantly, this was associated, when we looked at the paired biopsies, with a decrease in the number of regulatory T cells, here shown in this multiplexed immune fluorescence image, pre versus post administration of the DTA1 antibody. And in fact, there was very nice correlation between the patients who had a reduction in the number of regulatory T cells in the peripheral blood and those who had it in the tumor. So the question then became, why were we not seeing anti-tumor activity in this study when we were observing that the drug has hit its endpoint? Well, in fact, we went back to our mouse models and evaluated this using a suboptimal system where the mouse is treated at day 4 versus an optimal system at day 7. And we showed that there was still an ability to reduce the number of regulatory T cells even in the late day 7 time point. So then Roberta went and looked at gene expression profiling and showed that there was an enrichment in cells that had markers of dysfunction, expressing T cells expressing LAG3 and PD1 in the day 7 compared with the day 4 GITR-treated cohorts. And so this was a call out to combine PD-1 with the GITR antibody, and in fact, we showed improved tumor outcomes in that setting, and also with a favorable return of the T-cell phenotype to a less dysfunctional one, and also better tumor killing with this combination as well. So then we took this to a clinical trial with a combination of PD-1 and TRX-518, and although the trial could not be completed due to financial difficulties that the company sustained, we did end up publishing this recently, showing that there was some observation of anti-tumor activity with this combination. I would posit, though, that this was an important example of a trial that really should have focused much more on the pharmacodynamics rather than being cast aside just because there was no single agent anti-tumor activity. So in conclusion, one of my thoughts is that we should always consider, did the drug fail or did the trial fail to evaluate it intelligently? We should remember that translational research is a team sport. We need to collaborate with colleagues from all disciplines to reach the best conclusions, and we should not stop asking why. I'd like to thank my entire team now at Weill Cornell Medicine, and most especially patients and their families for their contribution to this work. Thank you.